This is Dr. Jaitly, your cardiologist, on your favorite website, MuniMeterHealth.com, which is dedicated to educating you about the human heart and its illnesses. Thank you for associating with us on the 2 social media channels from across the globe. And I appreciate your enthusiastic interest in furthering my knowledge that I can really provide to all of you at freely, primarily for clinical education and patient education as well, to improve the patient health literacy in order to improve the clinical outcomes. So thank you again for associating with MuniMeterHealth.com. First, housekeeping rules. Let's get those done away first. First things first. Number 1, again, for interns, residents, fellows, and my dear medical students, please consider this as a supplement, not a text, and consider using your text primarily for your exams, and then of course use this as supplement because these are short video formats, primarily to quickly give you the pearls and the grasp the knowledge as you're about to take the exams or about to see the cases in your routine day-to-day practices and rounds. 2, I also suggest that this is not a clinical advice. It's primarily an educational tool, a channel that's being provided to all my general masses as well as all my general viewers and the medical fraternity as well. So having said that, without any further ado, let's delve into the subject matter. The matter of the subject here is, today we're going to be talking about the management of PAD. I think we talked about the diagnosis of PAD and predominantly how do you stratify the mild, moderate, and severe disease based on the ankle-brachial index, which can be done in the office settings. Now remember, there are other diagnostic tests which are very, very important here. You can do a CTA. Again, this uses some contrast, remember that, and we'll just talk about that in a second, because you have to be sure that the renal functions are in top shape, okay? Because you really don't want to do subject the person to confirm a peripheral arterial disease in that individual when you're not going to take that patient for interventional surgery. Unless and until an interventional surgery is planned, you really don't want to do a CTA in these individuals, because then then most of these patients, even with mild renal disease, they can be considered to have taken for surgery there. MRA, remember that MRA is also the magnetic resonance angiography. This uses gadolinium. Remember that. That's also a contrast agent, and that is it causes renal fibrosis. So that is also renal toxic. Remember that. So these patients, again, they are not totally free from danger from the side effects from the contrast being used. But remember, if these patients have peripheral arterial disease of a very significant nature, and these patients are going for intervention and they have been cleared by vascular surgeons, by cardiologists, etc., provided they have all met their other requirements, and we'll just talk about that also in a second. So gadolinium and contrast agents, they are definitely contrast agents which are very, very hurtful, but at the same time, if the kidneys can handle it and the patient has stopped renal functions, you're okay to use these testings. Again, MRA and CTA can help localize, remember that, they can localize the PAD. They can tell you exactly where the disease is, whether it is in the aorta, whether it is at the bifurcation, whether it is in the at the deep femorals or the aortoiliac levels, or at the superficial femorals as we go along, or it's at the posterior tibials, dorsalis pedi, or versus popliteal arteries. So depending upon where it is, one can actually see these vessels. So just so that this is a diagram which is from my previous video, so I just kept it here handily available, so this way we can discuss the PAD here as well. Okay, so now having defined that, so let's move on to define what are the various certain locations that could be a clinical astute physician will be able to say. Now, if the pains are occurring, say, at the buttocks or at the hip region, where do you think is the obstruction? Well, the obstruction is very clear. It is either at the aorta or it is at the aorta-iliac junction. Remember that. So that's the place where, and we'll show that in a second. So remember that. The second thing is if the patients have pain. Now this is pain or claudication. We are talking about intermittent claudication we talked about. So one is buttocks and hips. Second is upper thighs. If it's occurring in the upper thighs, where do you think your obstruction is? Well, it's in the deep femorals. Remember that. It's in the deep femorals, or it is also in the aortoiliac regions. And 3, if it is occurring in the lower thighs, then write the complete lower thighs, then it's occurring in the superficial femorals, they could be involved. And then of course if it's occurring in the upper popliteals, then we know it is the superficial femoral plus maybe popliteal involved. And if it is occurring in the lower popliteals, popliteal region, lower calf region rather, I should say, these are calves. And if it's occurring in the lower calves region, then of course you are talking about the popliteal, distal popliteal, if you will, distal popliteal obstruction. So various obstructions can occur, and I can show you that in the diagram here, for instance. Now, aortoiliac, if that is the case, then the pain is normally in the buttocks, even up to aortoiliac, and in this region, it's in the buttocks. In the deep femorals, you're looking at the upper thighs, and as you proceed further, it's in the upper thighs, because now you're in the superficial femoral region, so this is superficial femoral. Then you go to the popliteal vessels. This will be all in the calves. All the pain will be residing, mostly the intermittent claudication will be present in the calves. And then you go to the ankles and the lower shin area, that will be dorsalis pedi and the posterior tibials. Posterior tibials will be involved, or the dorsalis pedi will be involved. Okay, so a site of pain, again, it's not very specific, but the fact is that one can really help locate what is going on in these patients depending upon the site of pain of the intermittent claudication that tends to occur. Now, what are the medical managements? Now, immediately once you've decided that these patients need to be treated, then obviously one of the things that you really decide to do is first put them on medical management. So what is the medical management? Aspirin. Aspirin is a wonder drug. Remember that. It's an antiplatelet agent, but please ask the risk for allergies, because aspirin allergies can be really, really dangerous. One patient can bleed to death. Two, patient can have ulcers, etc. So just be cautious. Aspirin allergies must be ruled out first, and then give an aspirin. Aspirin, or if somebody is allergic to aspirin, you can also use clopidogrel, also known as Plavix, if you will. Now it's generic. So clopidogrel can be used, and they both are wonder drugs, and they've been able to reduce the incidence of patient going for any peripheral arterial intervention by 25 to 30%. So remember that. That's wonderful. And then, of course, they also prevent myocardial infarction, prevent strokes, and then prevents angina from progressing into unstable angina and acute coronary insufficiency. So these are wonderful drugs, and aspirin is being a wonderful drug in this setting as well, in the peripheral arterial disease management. Secondly, you'd like to use, so having defined that, aspirin or clopidogrel. Gingko, have you heard of Gingko Biloba? Which is it's an herb. Obviously, it's an herb extract, and remember that this is it's a naturally occurring herb. And Gingko Biloba has been shown to improve the pain-free walking duration. Remember, the intermittent claudication lessens and all those pain-free walking duration. So if the patient is walking on the treadmill here, and say normally this patient was able to walk only 3 minutes to 6 minutes, now is able to walk even further and further and further, say 8 minutes or so. So Gingko Biloba has been shown. Another agent which is very, very importantly used is silostazol. Remember that. It's a difficult name, but Silastazol, silostazol. It's a phosphodiesterase inhibitor. I call it a PDI. And this drug has been also shown to improve the pain-free walking. So remember that. It's also been shown to improve pain-free walking in these individuals. So the IC is, or intermittent claudication is lessened. IC is lessened by silostazol. The only contraindication, remember, in these patients is for heart failure. If you have a heart failure in these patients, do not use silostazol. That's a contraindication. Do not use heart failure patients silostazol. Okay. Now let's move on to, so now where would you start giving endovascular interventions or say surgical interventions? So endovascular interventions are normally PCIs, or they are PTCAs, if you will. Okay, so one can open up with a balloon and open up these arteries by that mechanism. So it's like very similar to PTCA, but PCI, the stent. Now, how does the stent work? Now, let's understand that stent briefly. Here's your artery. Now, if the artery has an obstruction, for instance, it's going down here like this, and then you have an obstruction going down in this fashion here, and then you have an obstruction here as well, and these are all atherosclerotic plaques, whether it's thrombotic or embolic, like we talked about, or they could be originating by catheter manipulations, for instance, sometimes can lead also to embolization and thrombus formation. So once that occurs, what happens is over a period of time, all of these things can get obstructed, right? So you may have platelets and fibrin and all these things. So this is where the thrombus occurs. So the flow is compromised. It used to be a big flow. Now it is a smaller flow because of only a small flow because of the obstruction, the narrowing of the artery. So now when you put a stent, what is a stent? A stent is primarily placed here. Now this is where the stent is going to go. It looks like a ballpoint spring, I always say. That's very analogous. And once you deploy the stent, all of this will be compressed. So as a result, what will happen is you'll have an obstruction which will actually only get better, and you will be able to see that all of this could be erased here, for instance, and same thing will happen here. So this the obstruction can be erased, and one can actually see only, let's get back to the vessel here, for instance, or rather here, and then say if you can use this as and the artery is totally cleaned again. So what happens, the spring is now sitting within the artery, and all of that can just actually clean up the whole vessel. So the atherosclerotic plaque could be either compressed, and all this could be compressed, and the flow will be reestablished here. So now the obstruction is only minimal, and the flow is again reestablished here. And it's so this is the mechanism how the stent really works. So just to let you know. And the stent, remember, once you place the stent, then post-operatively again you have to still manage these patients with aspirin, with Plavix, and of course management of primary cardiovascular risk modification. Now what are the cardiovascular risk modifications one does? So cardiovascular risk modifications are very, very important. Risk reductions can be done if you I'll write it like that. So hypertension, be better controlled. So 120 over 80 is your goal. You want to get the pressure down. Okay. Diabetes, be better controlled. So A1C, if it is closer to 7%, that's wonderful. Now remember that it hasn't been shown that the closer the A1C, the better is the peripheral arterial disease. But by the UKPD trial, UKPDS trial, UK peripheral arterial disease trial, if you will, that showed that A1C, if it rises by 1%, that increases the likelihood of peripheral arterial disease getting operated by 25 to 28% or so. So it is a significant number. So obviously A1C should be as close to 7%. We like to keep the diabetics as controlled as possible anyway. So that's a given. So hypertension, be better controlled. Diabetes, be better controlled. And then smoking. No smoking sign is on. So remember that. No smoking sign is on. And I would rather put that with an asterisk here. Because the moment the patients, even after post-operatively, they get the PCI done or say endovascular intervention done, these patients go back to smoking. All of these stents will just close. So remember that. Even post-operatively, you have to manage the hypertension, manage the diabetes, make sure they're not smoking. So that's why intensify. And then the lowering the cholesterol, remember that. So once you lower your cholesterol, where specifically the LDL needs to be managed and should be less than 70 or so. So that's your goal, 70 milligrams %. And believe me, that'll be a big risk factor reduction here once you lower the cholesterol with any statins like atorvastatin or lovastatin, etc., etc. Okay, or simvastatin. So these are the risk factors, and of course if homocysteine is high, then you have to lower the homocysteine levels and other risk factors that you can also look through. Unfortunately, you can't do much about the genetic because that's too late to modify. So cardiovascular risk modifications are very important. Endovascular interventions by PCI is important. And then surgical, very important. When do you do a surgical intervention? The surgical interventions, there are only of two types. One is by end-arterectomy, I call it. So end-arterectomy. And the second is a bypass. So you offer a bypass in the aorto. I'm sure you've seen patients going for bypass like aorto-iliac bypass or aorto or iliofemoral bypass or fem-pop bypass, we call them, different bypasses depending upon where the obstructions are. And if the obstructions, for instance, are, say, at this level, you can do an aorto-iliac bypass. If it is at this level, you can do an aortic femoral bypass. If it is this level, the femoral popliteal bypass, and then popliteal and distal bypasses are here as well, done depending upon where the locations are. So bypasses are very important. So normally they are reserved for patients where you have small caliber disease. So remember, small caliber vessel disease, and then long lesions. Now what is long lesions? Anything more than 5 millimeters. So remember, less than 5 millimeters, you can do a stent. So PCI and PTI, remember, less than 5 millimeters, you can do a stent. And they have to be in big vessels, remember. So PCI and PTCA is normally done in the aorto-iliac region or iliac region or deep femoral maybe up to that point. But beyond that, it's always end-arterectomy or bypasses, remember. So and bypasses, of course, they are more definitive therapy, but all these patients will still require to have aspirin and Plavix on board, and then, of course, hypertension reduction, diabetes control, no smoking sign will be on all the time for these patients, and, of course, keeping the LDL as close to 70 as possible. That'll be very, very desirable. So this was in a nutshell. I was just going over the management of peripheral arterial disease. Hope you enjoyed listening to me on MuniMeterHealth.com, your favorite website. Once again, clinical education and patient education both are very important to improve our clinical outcomes in our patients, and that's been my initiative in the past 40 years of my practice, and I have continued that now through my video format, and I'm able to reach out to the world, and I feel very, very happy and delighted about that. So again, do not forget to press the like button. Please write your questions, your suggestions, and I make it a point to answer within 24 hours because we are receiving a great deal of responses, and again, our attempt is to answer the question within 24 hours to all of you. Okay, so long until next video. This is Dr. Jaitly.